Sounds good.
Okay, thank you. Yeah, I was so excited. Anyway, you didn't really miss much except for Irene Bello, which you could read. She started out in our neuro ICU and then started enjoying taking care of neurologic problems. And she's a great example of how important our nurse practitioners are. Let me get to this. Okay, coming events. Slicer Dicer training session is this afternoon at the Massey Conference Room. Elijah, if I have that wrong, just put in a note, 5 to 6, pizza served. People are really enjoying it. And our D&I committee is holding its quarterly meeting over Zoom tomorrow. Just ask Andrew or Will for more information. AJ Sampat is doing a Zoom lecture on November 27th about his experience as a neurologist, ALS patient, and father. Roshni has more information on that, and there'll be no Grand Rounds lecture next week. Our holiday party is 1 month away, and I guarantee you it's more enjoyable than these pictures seem to imply. This looks like a North Carolina Neurologic Society meeting, but it's actually a good time. It's at the JB Duke Hotel, December 15th, and please RSVP to Maria. I had mentioned this before, but Alexandra Rowe is doing a health disparities research study. If anyone's interested, email Will and he'll set you up. This week's All-Stars, Dr. Kim Johnson, who gets the award for her work in rolling out the new lecanemab pathway. And she was nominated by me. So I don't think I have nearly as many nominations as Dylan, but I'm working on it. And guess what? People really appreciate their coffee cups, right? How many of you have coffee cups? Raise your, a lot of coffee. Chris, you don't have a coffee cup? Someone has to nominate Chris, come on. All right, Shruti Agashi was the first author on a paper looking at intracranial hemorrhage associated with putting those little needles and swords into people's heads to monitor epilepsy. Well, hardly a surprise. Happy Diwali. I have to tell you that of the years I've been doing this, I feel uncomfortable telling people about celebrations that I have absolutely no knowledge of, but every year we do Diwali and people submit pictures of their family and it looks like it's always a great time. So it's for the Hindu, Sikh, and Jain faiths. And thanks to everyone who submitted photos. And Will is looking for some Thanksgiving photos for people to submit. Yeah, Diwali always seems to be a good time. No one's ever invited me to their Diwali party though. Jay Lusk, internal medicine intern par excellence, was a finalist at the American Heart Association conference on looking at the survival of forests. So it was presented at the AHA conference in Philadelphia. That was a joke, by the way. Promotions yesterday came rolling through. Birgit Frauscher to professor, Mike Lutz to professor, and Simon Davis to associate professor. So a little round of applause, all very well deserved. Whoops, sorry. Again, we're looking for our APP lead in neurology. Send a CV and a one-page statement to Megan. There is a huge demand for this year's NeuroFleece. I was modeling it the other day. I think it's going to be a big hit. So for all the residents, you get your free one, but make sure Tico has your size. All faculty and fellows can get one for $30. I'm paying the other $30. So I think we've got like 70 orders for non-residents this year. And then the Christmas party, December 15th. And I know you've all been waiting for the Joro update. How many were here for the last Joro update? Come on, you were here, weren't you here? The spiders? Okay. So they're coming. These giant spiders. And it hit the news because there was an article last week from Clemson looking at how these spiders are moving. And they started in Georgia and they're coming for us. And I love the headlines. US News headlines in early 22 are awash with sensational reports of the pending apocalypse. Giant spiders from Korea and China were spreading throughout our country, dropping from the sky, and they do drop from the sky. And they're that big. Look at those things. This is how they move. They make nets or webs that are 10 feet wide. And when the wind comes along, it gathers them up like a parachute and spreads them. And they started out at this little green spot in Georgia. And over 5 years, they've migrated this far. And I did a little math. In 5 years, they're going to be all over us here in Durham, parachuting down from the sky like little paratroopers. They say they're harmless, but they're disgusting. Yeah. Oh my God. It's going to be awful. I think I'll be in a stage where I won't even believe they're real. I'll just think they're hallucinations, like giant spiders parachuting from the sky. But they're coming. We'll have another update in a couple of years. All right. Here's today's CME code. And today's case presentation is Dr. Roshni Dhoot. Did I do it? Do you have to change the share screen? That might be sharing mine. No, you're still sharing mine. That's, yeah. Oh, yeah. Sorry.
Thank you.
I can't believe I muted all.
Okay, good morning, everyone. Today's case is about a 43-year-old male with a history of hypertension and hyperlipidemia. He presented to an outside hospital with 1 month of progressive and profound weakness in his lower extremities. He also had some associated symptoms of blurry vision, metallic taste, and severe ankle and hand swelling. He was admitted due to inability to walk. At that point, he was dependent on a wheelchair to move around. As part of his workup, he had a CBC with a hemoglobin of 10.6, a normal CMP, and a urinalysis which showed 2+ protein. He had a lumbar puncture which showed a protein of 311. His MRI brain, cervical, thoracic spine, with and without contrast were all normal, but the MRI of his lumbar spine showed a mild enhancement of his cauda equina nerve roots. At that point, it had been a month, so he also went EMG evaluation, which showed a patchy acute motor denervating process concerning for Guillain-Barré syndrome. He was given IVIG 2 grams per kilogram over 2 days, had very significant and pretty rapid improvement of his very profound weakness. He underwent additional workup. His ANA was positive, and he had several antibodies concerning for lupus Sjogren's syndrome. He also had elevated immunoglobulins and free light chains. At this point, he was transferred to Duke for rheumatologic evaluation. When neurology was involved, his motor symptoms had resolved. However, he had pretty significant sensory symptoms, absent proprioception at his distal extremities, and he continued to be areflexic throughout. He was started on Plaquenil empirically, but continued having increased urine proteinuria. At this point, he underwent a kidney biopsy, which showed that he had class 5 lupus nephritis. He was treated now after the IVIG course, subsequently with steroids, and also started on Cellcept. So the diagnosis ultimately was lupus, presenting initially with Guillain-Barré syndrome. Lupus uncommonly presents with an axonal polyneuropathy. However, the last time this was published in April 2022, there were only 20 case reports dating back to the 1950s, with demyelinating polyneuropathy as a presenting feature. In all of the cases where lupus presented as Guillain-Barré syndrome, the patients had class 5 lupus nephritis. So there are several lupus neuropsych syndromes that we're familiar with: headache, acute psychosis, stroke, demyelinating disease in the central nervous system, and then different types of neuropathy: sensory axonal polyneuropathy, vasculitic neuropathy. Notably, this patient's ANCA was negative, and demyelinating neuropathy, as in this case. The pathophysiology is not clear, but it's thought that both cell-mediated and humoral processes may play a role. There are 4 types of anti-neuronal antibodies: anti-lymphocytic, anti-phospholipid, cardiolipin, and lupus anticoagulants, which of course are also seen in lupus, and then anti-ribosomal. So because the antibodies that are seen in lupus are also anti-neuronal antibodies, the thought is that there's cross-reactivity between these autoantibodies in lupus and the neuronal antibodies that may cause damage to the nervous system. Notably, NMO and lupus are comorbid at a higher rate that would be expected due to that autoimmune phenomenology. This is important because identifying the comorbid disease may also change the long-term management, as in this patient's case. So this is so rare, when should we suspect or diagnose this? It should be suspected when there's no clear antecedent infection and when the systemic symptoms don't fit with GBS, specifically this patient's significant renal involvement, anemia, and then also positive ANA and positive double-stranded DNA antibodies. These patients may need IV steroids, Plex, and cyclophosphamide. So back to our patient, he had a prolonged course at rehab. He overall is doing well from a neurologic perspective. However, his lupus remains difficult to control and is undergoing different trials of immunosuppression.
Thank you, Roshni. That was wonderful. All right. Well, I'm not going to share screen for the intro. Next week, I'm going to print this out so that people don't have to see me reading it. But anyway, today's speaker is Brian McGrory. So Brian's an associate professor of neurology and ophthalmology. How long have you been here, Brian? 3.5 years. I was going 5 because you've accomplished so much. He's the director and founder of the Duke Eye Stroke Clinic. I got those words backwards. He's from Dublin, Ireland, which is why we started off with a little decoration on our introductory slide. He got his long lettered medical degree from University College Dublin, and then did his residency and fellowship in stroke at Yale. And at Duke, he did a master's in clinical research, which several of our young faculty have done. He's been academically prodigious with 107 articles so far. I mean, I don't have 107, and I am twice his age. The 7 book chapters, a recipient of the Early Career Investigator Award from the American Heart Association, and a K23 award from the National Institute of Health, National Heart and Lung and Blood Institute. But I think of all these accomplishments, the most amazing thing is the Eye Stroke Center. And in my career, I've seen this maybe 5 to 10 times. Really talented young people have a passion for something that's kind of been neglected. And just through their efforts and excellence, suddenly everyone says, well, why didn't I do that? But you all can. And Brian should be an example, because I've just seen this done over and over by, our symbol. Remember our symbol with the 5 little sprites? And I always talk about there's the one in gold, because success comes from that one person, always. But that one person, if they're in the right setting, can accomplish what they want to accomplish. So you folks have to be the gold person. You have to be what Brian has done to set up some area that really makes you passionate, and then it's always successful. So anyway, with that as an example, Brian's going to talk to us about the heart and the eye. Thank you, Brian. I'll just stay here to make sure you don't mess up.
Okay.
Got to share. Sure. So find Zoom now. See? Not so easy. There you go.
No.
Share screen. And then share on this. Perfect. And then make it this. And then hide your floatings. Yep.
Sorry. Okay. Well, thank you, Rich, for that very, very warm welcome. And, I appreciate your, kind words about the Eye Center, but actually, and I do return to this at the end of the talk, it's actually the resident physicians who make the entire eye stroke program work. So I want to take the chance to thank each and every resident who's attending today and who's attending over Zoom for your hard work on that, because it's actually a resident-driven and resident-led program, and I'm just sort of the cheerleader in the background. So the heart and the eye. So these are my disclosures. Okay, so as many people know, I'm passionate about the study of eye stroke, or sometimes called central retinal artery occlusion. Sometimes people ask me why. And I think the reason is probably twofold. I mean, the first is that during my training, I think I was affected by, a couple of cases that I saw personally of people who suffered with eye stroke and who I felt had sort of perhaps fallen between the cracks between specialties and who had a really disabling, difficult to treat stroke syndrome that was neglected because it didn't quite fall within neurology or quite fall in ophthalmology. And the second thing is, I think that it's actually a condition that we can study and treat if all the right specialists come together in a coordinated fashion in the care of the patient. There are many conditions in medicine where people are trying to sort of push the boat in terms of, gene therapy or stem cell therapy or, artificial intelligence. But actually, I think with eye stroke, we have many of the tools that we need to study and treat this condition if only people worked together as well as they do at Duke Medical Center. And so it was in this spirit of wanting to collaborate that we went to the American Heart Association a few years back and wanted to put together a scientific statement where we offered some considerations for the management of people with eye stroke. And the purpose behind all of this was to basically get neurologists, neurosurgeons, ophthalmologists, optometrists, cardiologists all together on the same page to basically say, well, what do we know about eye stroke and what can we do to treat people with eye stroke? And so we originally went to the American Heart Association and said, well, look, we'd like to write a guideline about this condition, a guideline where a professional body comes by and says, what do we actually need to do to treat people with eye stroke? And the American Heart Association basically came back to us and said, you don't have enough data or evidence to say anything about how people with eye stroke should be managed. And then we kind of said, well, what if we just want to say some very basic things like people with eye stroke should go to the hospital, or people with eye stroke should have an echocardiogram done as part of their care, just like any patient with stroke. And they went back and they talked and they said, you can't even say that. You can't even tell anyone in a professional sense that you have to do an echocardiogram or heart rhythm monitoring on a person with eye stroke. And they weren't wrong. There actually wasn't a whole lot of data about that. And but at the same time, this conflicted with a few of my own kind of personal kind of professional experiences where I'd seen people who I, quote unquote, knew had an eye stroke and that it was caused by a problem with their heart or caused by a problem with their heart rhythm. I mean, for example, I saw at one time a 47-year-old gentleman, we actually wrote the case up, who presented with acute painless monocular visual darkening, was diagnosed with eye stroke and was found to have no other potential substrate other than a large left ventricular thrombus on his transthoracic echocardiogram. So that's a person in whom, it seems like most likely had a blood clot come from their heart. And the second was, this actually after the statement came out, but a couple of years back, I saw a young 25-year-old gentleman who presented with an acute cilioretinal artery occlusion. This is a small little accessory vessel that's off a slightly different circulation, but very, very near to the central retinal artery, who was in the peak of his health. He was an athlete. He had no evidence of carotid disease whatsoever, but was found to have an infiltrative cardiomyopathy owing to sarcoidosis and developed in a depressed ejection fraction and went on to have this eye stroke. And we also, we've all seen the case of someone who gets an eye stroke after they have an angiogram, or, the person who has an eye stroke at the same time as they have bilateral embolic appearing cerebral stroke. So there's all this sort of circumstantial evidence that we see in our daily practice and that I've personally seen, quite a number of times that made me think, well, gosh, there must be some people who have this. The other observation is that, we recently observed that intravenous fibrinolysis may be effective for the treatment of eye stroke. We know that, like with eye stroke, with treatment of brain stroke, the quicker you give intravenous thrombolysis, the more likely it is to work. And this sort of, again, flies in the face of the traditional teaching, which is that eye stroke is almost always caused by calcium or cholesterol emboli from the carotids. It suggests that at least a proportion of the occluding lesions, the culprit lesions causing eye stroke, are fibrin-based that are amenable to thrombolysis. This is a diagram of the central retinal artery, and sort of the counterpoint to what I just said, the observations that I made, is that it truly is a very, very small blood vessel, and that to get from the heart to the central retinal artery is a rather winding and circuitous route, starting with, the aortic valve, then going to the aorta, the common carotid artery, internal carotid artery, and the extracranial segment, intracranial segment, and then the ophthalmic artery, and then from the ophthalmic artery, the central retinal artery. So it really is a truly winding and circuitous route. This really is a very, very small blood vessel. It's about 160 micrometers in diameter. So thinking of how a typically large clot from the heart would make its way from the heart to the central retinal artery is, it's a little bit hard to wrap your head around. The artery is actually so small that most of the time we can't actually even see it. And when I say most of the time, I mean in almost all clinical routine kind of imaging that takes place. So this is a sagittal section of a person actually in normal health without CRAO, where we can just about make out the ophthalmic artery, but we can't see the central retinal artery. This is so this is a CTA. This is an MRA, and then this is a relatively new technique called cone beam CT angiography. And this was published by a friend of mine at NYU Langone Medical Center, Eitan Raz, where this is a very specific high resolution CTA technique that can only be done when a person is actually under general anesthesia because of how high the resolution is. But by this technique, we can actually just about start to make out the central retinal artery. Here we can see the central retinal artery juxtaposed with a branch of the ophthalmic artery. In this cone beam CT angiogram picture, we can see the central retinal artery running along the central retinal vein. And here we can actually see the central retinal artery as it arises at the optic nerve summit and actually starts to bifurcate into the branch retinal arterioles. And again, this is about 160 micrometers in diameter. It truly is very, very small. It's about the width of a coarse fiber of human hair. So again, what are the chances that a blood clot from the heart would actually go there? So we set about trying to study this condition. It's a very challenging question to address. For a start, eye stroke is rare. It's only about 1.8 per 100,000 people per year, and about 10 per 100,000 people over the age of 80. So it's less. It's about 1% or less of strokes. But having said that, it's more common than many other conditions that we all think of as being very, very important, such as stroke associated with arterial dissection or bacterial meningitis, things like that. It's rare when you compare it to the behemoth of brain stroke, but not on sort of a population level. And so we needed to use large data sets that would allow us to actually identify a meaningful number of people with eye stroke, but also think of a common exposure, because if we wanted to use a rare exposure or a rare risk factor and then a rare outcome, that would be very, very challenging. So the first thing I chose to do was to study atrial fibrillation. Why? Well, atrial fibrillation is one of these established, risk factors for ischemic stroke. It's very, very common. It's one of the most common. In fact, it is the most common arrhythmia in the elderly. It's also something that could be treated, but also something that's undertreated. So about 50 to 60% of people with AFib who should be on anticoagulation are on anticoagulation, and the balance are not. And I thought that was also a nice opportunity for study. So when we think about atrial fibrillation post-stroke, we often refer back to what's called the Crystal AF study. And this was a study they published back in 2014, where they took people with cryptogenic stroke or TIA and randomized them to either implantable cardiac monitors that can look for evidence of AFib or usual care. And what they found in this study was that the longer you monitor people, the more likely you are to find occult paroxysmal atrial fibrillation. If you monitor people for 12 months, about 15% of people are found to have AFib. If you monitor for 3 years, about 30% are found to have atrial fibrillation. And, without commenting on whether this atrial fibrillation was causative or merely a consequence or unrelated, a coincidence, this certainly, posed an interesting question about the role between paroxysmal atrial fibrillation and cryptogenic stroke or TIA. Now, this is a harder question to address for eye stroke because it's again, a lot rarer. So we chose to use a kind of a slightly non-textbook approach using already aggregated data sets. So we went to Medtronic, which is the large device company, and we used what's called the Medtronic CareLink registry. And so this is a very, very large proprietary data warehouse that's capturing heart rhythm monitoring data of patients with either a pacemaker, implantable cardiac defibrillator, or an implantable loop recorder that's capable of monitoring for atrial fibrillation. And we were able to cross-reference that with what's called the Optum Electronic Health Record, which is a large, again, insurance-based administrative claims data set. And we were able to actually cross-reference the two and find about 460,000 people in common between the two data sets. So people in the Optum Electronic Health Record, but also those within the Medtronic CareLink database with a device capable of monitoring for AFib. And from this, we were able to select out 100 patients with eye stroke, 1,000 matched control patients, and then we also took the balance of patients within that cohort who had cerebral ischemic stroke and who otherwise met inclusion criteria. And what we found was that after a diagnosis of eye stroke or central retinal artery occlusion, the the sort of hazard of developing atrial fibrillation mirrored very precisely that seen after ischemic stroke. So again, doesn't tell us whether this is sort of cause, consequence, coincidence, correlation, or compensation, but it certainly suggests there may be some sort of association between CRAO and paroxysmal atrial fibrillation. So the next step was we went and did a study using data from the healthcare utilization project, and this was led by Jay Lusk, who's currently a first-year internal medicine resident going into potentially going into neurology next year. And what the healthcare utilization project does is it's a state-level initiative that takes data on consecutive non-federal hospital discharges, and it slices up each hospital discharge based on the diagnosis codes that are entered at the point of discharge. And we got the data from this project from New York, California, and Florida. And the reason we chose those states is because they're very, very large. It captures just under a third of the total population of the United States. It's diverse, and because they have the ability to link inpatient and emergency department data sources. Now, the caveat to this study is that we could use inpatient, we could use emergency department data, but we did not have data on outpatient treatment, skilled nursing facility, acute rehab, or LTAC, or indeed other venues of care. And so what we did was we took patients with hospital documented atrial fibrillation, and then patients without hospital documented atrial fibrillation. And we found that they differed, unsurprisingly, in many, many respects. The people without AFib were substantially younger, had substantially fewer comorbidities. And what we found was that in unadjusted analyses, atrial fibrillation was a strong risk factor for the development of eye stroke. Of course it is. The people with AFib were older, had more vascular risk factors, they were sicker, and it wasn't surprising. And so the unadjusted hazard ratio is 2.5, but when we actually adjusted for the metrics that I just discussed, we actually found that there was no substantial difference between the people with AFib and without. And we tested this both in our primary analysis, but then in a number of sensitivity analyses as well. And so it seems that, including in certain sensitivity analyses, that atrial fibrillation was not just not associated, but actually protective against the development of eye stroke, a very, very counterintuitive and not really biologically plausible finding. Why was that? Well, when we look back at the data sets, so again, from California, Florida, and New York, we go through the individual year by year, and we found that actually the occurrence of eye stroke seemed to vary with time. There seemed to be these very strong secular trends, particularly in Florida and New York, which doesn't make sense unless we think there's some sort of epidemic of eye stroke that's sort of happening. And what I think is happening there is that this is an artifact of coding that's taking place, which is that over time, as there's greater recognition of eye stroke, people are more likely to be coding it. But what this tells us is that there's under recognition and incomplete sort of penetrance of eye stroke into administrative claims. And so the second thing is that there seems to be a great degree of unmeasured confounding as well. So we see the unadjusted hazard ratio is 2.5, but the adjusted is actually 0.9. And what that means is that there's a huge amount of confounding, meaning that there's so much difference between the AFib and non-AFib groups that the statistical models have to work very, very hard to actually find out a true, independent association. And so what I kind of like to say is that, there's the measured confounding is the smoke, but where there's smoke, there's fire. And there's likely a huge degree of unmeasured confounding as well. Other properties of the people with AFib or not that made it so different that, that it's hard to make sort of firm conclusions from this. So how would we actually test this? If we wanted to do an experiment and answer this for sure, does atrial fibrillation cause eye stroke? Well, what could we do? Well, we could do a randomized controlled clinical trial where we randomized some people to a procedure that caused atrial fibrillation and some people to an identical sham procedure that did not cause atrial fibrillation. Does anyone think that would be a good idea to do? Roshni? No. We could randomize people who have AFib to either blood thinners or not, so we could see that just as a very simplistic construction, blood thinners prevent many of the blood clots from atrial fibrillation. So we could randomize people to either anticoagulation or placebo, and we could see, does that alter the rate of eye stroke formation? Again, not a perfect experiment, but it would be getting a little bit at some of the unmeasured confounding that we saw. But again, I would suggest that that's highly unethical and not likely to work. It also would require many tens or even hundreds of thousands of patients. So the third approach, yeah. Yep.
Rather than all this controlling of all these different things, I would imagine there were like 10,000 patients without eye stroke working like that. Wouldn't you just find it would match them where you didn't have to then control for everything?
Absolutely. Yeah, that's definitely another approach. So when we deal with sort of like confounding, we can either adjust, we can match, we can weight, or we can stratify based on, you know, a person's sort of property within each individual covariate. And that's actually we went on to do that in the follow-up study. And you will see that, Rich, that we actually chose a hybrid matching and weighting approach. But yes, that would have been a very, very valid approach to use alternatively, and one which we're exploring. So you know, so the third, you know, option here is that we could do a randomized clinical trial, either doing a procedure to cause AFib, you know, doing both things or not, or used non-randomized data. And I think that options 1 and 2 are likely unethical, unfeasible, and impractical. But in designing the experiment, it's worth just ask ourselves, well, what is a randomized controlled clinical trial? It's not something that we often talk about too much, but, you know, because it's when you turn, you know, open the New England Journal, everything's a randomized controlled double-blind clinical trial, et cetera, et cetera. But really all it is it's an experiment. And it's an experiment that's done on, you know, an ethically challenging proposition, right? You're usually talking about giving one group of people a novel therapy and one group of people placebo, or you're giving one group of people a therapy that you think probably does work, we just need to confirm it, and another group you're not giving it. So it's basically an expensive, risky, and ethically challenging experiment. But fundamentally, it's no different to an experiment that's done, you know, in the laboratory. It's basically consists of 5 kind of key parts. It's got a sample, it's got an exposure, which is often the intervention. It's got a counterfactual, which is often the control. It's got a clear endpoint, and most importantly, it's got a plan in advance. But every single clinical trial is basically has to be defined by those 4 simple things: sample, exposure, counterfactual, endpoint. And, you know, the devil is obviously in the detail when it comes to implementing a trial. But fundamentally, it boils down to those 4 things. Just like any experiment that's done in the laboratory, when you read like a paper in Nature or Cell, you can identify these 4 key things. Now, those sort of more translational or basic papers tend to be a series of, you know, in some cases, dozens or hundreds smaller experiments with that structure. But fundamentally, that is what's going on. And because a clinical trial is so
because I would say in the lab, clinical trials are much more rigorous than rat trials.
true, but having said that, you know, in a rat, you are
Yes, possible.
fair. Okay, fair enough. Yeah, we can agree on that. We can agree on that. So when it comes to a clinical trial, because it's so expensive and so risky, it just so happens to be that these 4 things are done terribly well. You know, the sample is very, very well defined and well described. The exposure is highly monitored and controlled by the study team. The endpoint is measured by blinded endpoint adjudicators who are trained and audited, and each endpoint is registered on clinicaltrials.gov. The plan is prepared and published in advance. It's registered with the FDA. It's registered on ct.gov, and basically everything is done just very, very well. It's like, you know, what Rich was saying. You know, it's an experiment in the lab, but everything is, one would hope, in its highest expression, done to in a very, very high standard. But I would argue that of all of the properties of clinical trial, the thing that it does best is establish an appropriate counterfactual. Counterfactual just means the inverse, the flip side of the coin of the main exposure or intervention. And this is what a clinical trial really brings, a randomized clinical trial, because it allows you to compare the intervention with a control in a person who, you know, gets every other aspect of their care exactly the same, who doesn't know that they're getting the control, who their treating physician doesn't know they're getting control, who the outpoint adjudicator, you know, doesn't know that they're getting the control. And so it's one of the very few ways, not the only way, but it's one of the very, very few ways of establishing a valid counterfactual. And the reason that this is worth so much money is because it's basically such a high risk proposition, risky, and so ethically challenging. But we can apply some of these principles to non-randomized data. And there are particular questions that are infeasible, risky, unethical, where you can actually, if the experiment is constructed right, use many of the principles from a clinical trial in an observational study. So the first thing when we started out to study this was myself and Scott Lee, we talked about the endpoint here. So how do we know what the endpoint is? And so when we're using administrative claims data, we're using individual diagnosis codes that a person at the point of discharge has diagnosed a patient with. And what we wanted to find out was, is the diagnosis code corresponding to eye stroke, is it actually valid? And so Scott and I took 100 patients, 50 with eye stroke, 50 with another form of eye stroke, such as branch retinal arterial occlusion, vein occlusion, or central retinal vein occlusion. And we ascertained the sensitivity, specificity, and the other kind of parameters of accuracy. And we found that, you know, it was actually very, very accurate. The positive predictive value was 88%, which suggests that it's actually a very useful diagnosis code to use. But we also had to overcome some of the limits that Rich brought up and some of the limits that we found from a previous study. So we chose to use what's called the Medicare 5% sample. And this is a large administrative data set that takes all the patients who have Medicare in the United States. So that's people over the age of 65 and some people with dialysis or other chronic health conditions. But it takes a 5% random sample of those patients. And it's got a number of advantages. The first is that it's truly population-based. It comes from every single state. It allows us to attack multiple avenues of care. So instead of just inpatient and outpatient, it allows us to tackle pharmacy, emergency departments, skilled nursing facilities, basically every venue of care that you can possibly think of. And it allows us to do nested comparative effectiveness studies because we have pharmacy data as well. So it's actually a very versatile and flexible approach that we can use. And so for this one, this has been done in concert with Vineet Nalawadi, who's an extremely talented data scientist who's leading the analysis for us. Dealing with the Medicare 5% sample is no small proposition. There's people who spend 5 years just learning how to use it because it's got massive computational and data science approaches. There's missing data challenges. There's data archiving challenges. It really is a huge challenge. Jay Lusk wrote the design paper for this and has taken a strong leadership role in this project. And then Lauren Wilson is an epidemiologist and a methodologist from Population Health who's been supervising the overall statistical analysis plan of this. And so what we're going to do is we've begun a retrospective observational cohort study that we aspire to use a target trial emulation framework. So we try and adopt some of the elements of rigor that I discussed from the clinical trial within an observational study. And we've actually done a pre-specified statistical analysis plan. It's actually been written and essentially accepted with minor revisions at PLOS. And this is what we're going to do. We're going to take people with atrial fibrillation. We're going to take people without atrial fibrillation, and we're going to use a two-stage covariate balancing approach. The first thing we're going to do is take people with atrial fibrillation and match them precisely on a one-to-one basis to people without. And then we're going to assay any residual difference or covariate imbalance between the two groups and weight that out. So the first thing we're going to do is construct those samples. Then we're going to calculate the cumulative incidence of CRAO across both groups. And then we're going to model the difference in that using a Cox proportional hazards model. Then what we're going to do is to sort of assess for whether we've calibrated our matching and weighting correctly. We're going to use positive controls to make sure that we can replicate previously defined associations, such as associations between AFib and stroke. We're going to use negative controls, falsification endpoints, such as urinary tract infection and pneumonia, to make sure that there's not any residual confounding that's going on that we haven't been able to detect prior to that. And then we're going to do a nested comparative effectiveness study where we restrict it to people with atrial fibrillation, and we do a quasi-randomized study where we take people with anticoagulation and without anticoagulation, and again, match and weight to the greatest extent possible to try and determine whether anticoagulation reduces the risk of eye stroke. The reason for this is because this would be the equivalent of, in a laboratory study using like a blocking antibody or something like that to essentially, neutralize the effect of the atrial fibrillation. That gets very complicated because people start anticoagulation, they stop it, and we've worked through a plan where we're actually going to use anticoagulation in a time varying sense. But a challenging proposition nonetheless. So part one is going to be AFib versus no AFib. Part two is AFib and anticoagulation versus AFib without anticoagulation. So we're probably about a third of the way through this project thus far. And what we did was we initially started with an extremely large sample of just under 10 million patients. And in our initial procedure, what we did was we identified 530,000 people with atrial fibrillation. And then we matched using propensity score matching patients without atrial fibrillation. And we were able to successfully get about 536,000 people who were extremely well matched based on age, They were both groups 76.9. It was the sort of the mean age, balanced in terms of the proportion of people who, whose biological sex was female, well balanced across race, ethnic groups, and well balanced for the most part with respect to the different comorbidities. And again, this is just the first phase matching approach. And we insisted on getting an exact match on age because we were concerned about problems with our survival analyses coming up with a differential rate of death between the two groups. So we decided to match on age first and foremost, and then implement a propensity matching procedure after that. And then what we did was we actually took that matched group, re-estimated all our propensity scores, and weighted patients based on propensity scores such that the residual imbalances that were there, we were then able to get those out of our model. And so, for example, with heart failure, while initially there was a standard, a standardized mean difference of just under 0.1, that was then eliminated after weighting. Similarly with hyperlipidemia, similarly with hypertension. So we ended up with this really, really well proportion sample with very little covariate imbalance. And then when we run our modeling, we actually found out that atrial fibrillation, it seems to be an independent risk factor for eye stroke. So the unadjusted hazard ratio among the matched patients is 1.16. And when we adjusted with second stage overlap weighting, it was exactly the same. It was 1.16 with a 95% CI, 1.04 to 1.30, which suggests, again, for the first time, that that's an independent risk factor. What we're going to do next is run a series of positive and negative controls to interrogate why, to interrogate whether our matching and weighting has been appropriate. We're going to probe the robustness of our analyses through subgroup and sensitivity analyses. And then we're going to do a nested quasi-randomized study where we try and figure out whether anticoagulation, what the interplay is with anticoagulation and this risk. Then this is aim one of a much larger project. Aim two is going to be more biomarker driven and is going to examine the interplay between carotid stenosis and left atrial diameter. And aim B is going to determine whether patients with eye stroke have evidence of active microembolization. We've just started recruiting for those two projects. Yeah.
Hazard ratio 1.16. What would that hazard ratio be?
Yeah, we're actually going to figure that out. Yeah, that's going to be our nest analyses. Probably around 2.5 or so, something like that. Yeah, so it's smaller. It definitely is, but it's still there, But it's the actual hazard ratio hasn't been described for with this precise methodology. So actually, our next step, what our statistician is actually working on now, is getting that exact hazard ratio. So we'll be able to answer that pretty soon. I suspect it's going to be lower. Like the 2.5 figure is taken from like the Framingham study where they perhaps wouldn't have paid quite as much attention to the things that I mentioned. So it's probably going to be, I'll let you know what it is, but it's probably going to be lower. Yeah. Yeah, so I'm making no comment on whether I think atrial fibrillation, how it might be associated. Yeah, just that it's a risk factor. Yeah. So in doing all of this, and this is just to briefly conclude, what this brings up is a much larger idea, which is the use of causal inference methodology in questions in neurology. And why this all came about was, I was submitting a grant to the National Institutes of Health, and one of the feedbacks they gave in the first submission was that, while they liked the idea, they wanted me to use kind of more robust methodology, and they brought up this concept of causal inference. And when I got this comment from the NIH the first time I submitted the grant, I was really kind of trying to rack my brains as to how I would possibly address this and how I would sort of use these techniques. And I just went around. This is one of the great things about Duke, is that it's great to find collaborators. It's very, very easy to find collaborators. And I went around and I cold emailed, I think, 3 different people. And the first person got back to me within about 5 minutes. Her name was Dr. Fan Lee. And her office is less than 5 minutes away from mine. And it turns out she's one of the world experts on causal inference methodology. And so we've been working together for the last 2 years on this question, and actually 2 other parallel projects. And myself and Ying Zhan, who's a very good friend and colleague of mine at UT Southwestern, Jay Lusk, who's a first-year internal medicine resident, and then Alonso Guerrero Castaneda and Natalie Smith are second-year masters in statistical science students. And we've been actually working together as a group on, using the eye stroke project as essentially a prototype and then asking how we can address this in other disease states. And so, for example, there's one project we're doing where we're using a technique called difference in differences regression to determine whether migraine medications are causative of eye stroke. And we actually got awarded basically an R21 level equivalent grant from the AHA to address this question using data from MarketScan, which is another administrative claims data set. We're going to use the same technique to examine the association between dural grafting and cerebral amyloid angiopathy. And we're going to do this using a data set in Finland, the FinGen registry. And then we're also going to use a technique called instrumental variable analysis to look at the differential impact of mobile stroke unit care and outcomes across the United States. And we've got a seed grant awarded to study this, which we're going to leverage into a larger grant next year, probably through the AHRQ. And so it's an interesting area, and these are some of the people that I've been collaborating with. And I want to thank everyone on the screen here. I want to thank the funders who've made this work possible. And I just want to conclude by thanking again everyone in the residency program who, I've talked a bit about the research that I'm doing, but what I didn't touch on is the clinical care. And I think that the clinical care at Duke is actually the more interesting story. And it's the residents who take care of all this. So thank you to each and every one of the members of the residency program. Thank you to the child neurology residents as well, who I haven't listed on the screen here, but thank you. And my friends, Jeremy Wells and Dylan Ryan as well, for their leadership. So I'd welcome any questions, and thank you for your time.
It's just remarkable, and sorry for the questions, but it was so interesting. All right. They stole our clock, so I have no idea what time it is, but go right ahead. Any questions in the room? Come on, all this logistical mumbo jumbo. Go ahead, Chris.
Yeah.
Was that all? Were those codes all internal, or were they the same?
Yeah, so yeah, we did internal. Yeah, so we did a bit like what Elijah's going to be talking about earlier on. We did a slicer dicer, and we found 50 consecutive people with eye stroke, and then 50 people with allied conditions, and essentially blinded ourselves to them before we did the validation study. The reason we chose to use other kind of very similar conditions like branch retinal arterial occlusion and vein occlusions was we wanted to set ourselves up for failure, right? We wanted to make it as difficult as possible, but yeah, fortunately it turned out that it was a valid code. So it was myself and Scott Lee did that.
And anyone on the internet? BMAC?
So Rich, I was afraid that you're going to ask me that hazard ratio question.
Well, do you want to just for the young folks,
yeah.
Like if you read a lot of articles, there's something called an odds ratio, and he talks about hazard ratio. Do you want to make a comment on the two of them?
Yeah, no, it's to do with the kind of the underlying type of data. So like the odds ratios, if you're comparing to the proportions across two groups. The hazard ratio is if it's in survival analyses. It's when you're looking at time to event data. So we could also have calculated an odds ratio.
An odds ratio usually makes the data look better. It's a bigger number in most cases.
In many cases it might be. Yeah.
Sorry,
but a hazard ratio compares the
odds ratio is always makes your data look more fabulous.
Yeah, that's true.
But I mean, so for instance, we all think of this as clots, but I once read a paper about people with big PFOs. And people with big PFOs had large, higher blood homocysteine levels. And when they closed the PFO, the homocysteine dropped down. That's what I mean about maybe AFib is not just about blood clots.
Exactly. Yeah. No, that's a good point. And I don't know if Dr. Powers is listening on Zoom as well, but I think he'd have a lot to say about this. But what we know in AFib is that people with AFib are at higher risk for blood clots and strokes. We know that they come from the left side of the heart, and we know that anticoagulation reduces the risk. What we don't actually know is atrial fibrillation itself, the mechanism, or is atrial fibrillation just the smoking gun, or is it the smoke, whereas the fire is structural disease in the heart or other unforeseen problems. So you're right, we don't actually know, and I think that I'm using in this setting, I'm using AFib as sort of a surrogate for some measured or unmeasured cardiac process that predisposes to clots. Yeah.
Yeah, and again, I just want to use the example of Brian as someone who came here, penniless with just an idea.
Just the shirt on my back.
You
took me off the street.
An idea in his head for this, and you can see how far it's come through both his initiative and collaboration. I just think it's a wonderful story. So anyway, thank you.
Oh, and Rich, thank you for your support as well. You were very generously welcoming to the department, so thank you so much.
All right, everyone, thank you.